Executive video of microsurgical management of large lateral cerebello brainstem space trigeminal schwannoma type B. This 25 years lady presented with worsening headache, diffuse pain left side of the face, left ear diminished hearing, swaying while walking. Examination showed glaucoma score 15, left facial hyposthesia, Lemon 7th paresis, grade 2, left sensory neural hearing impairment with gait ataxia. With this, she was investigated with contrast CT scan brain, MRI scan brain, showed a large left cerebello brainstem space lesion with large cystic component with a significant pressure on the brainstem, midbrain, pons, and medulla and cerebellum with mild to moderate ventriculomegaly as shown in these images. With this, she was taken up for surgery, underwent in lateral position, left retromastoid suboccipital craniotomy, trans left lateral cerebello brainstem space approach, opening of the cisterna magna, opening of the arachnoid and the dissection of the tumor from the surrounding neurovascular structures and complete excision. These are the steps of retromastoid suboccipital craniotomy. We prefer to make retromastoid suboccipital craniotomy, make 3 burr holes, 2 superiorly, 1 inferiorly up to the foramina magnum, join the burr holes with the craniotomy cutter after separating the dura, underlying dura from the bone as shown here. We prefer to do little wider craniotomy in these cases as shown here. The burr holes are joined with the craniotomy cutter and the free bone is removed. Superiorly, the craniotomy goes up to the transverse sinus, inferiorly up to foramina magnum, medially up to the midline, and laterally up to the sigmoid sinus. The bone flap is elevated, free bone flap. The bone is nibbled and laterally up to the sigmoid sinus. Once that is done, we drill the mastoid laterally till we expose the sigmoid sinus laterally and transverse sinus superiorly. The mastoid air cells which are exposed during the drilling are waxed well to prevent the CSF leak subsequently. Once that is done, dura mater is opened in a cruciate manner. Now I want you to see here the cerebellum is bulging because of the large tumor. These situations we prefer to open cisterna magna and let out the CSF so that the cerebellum gets relaxed. Inferiorly and medially, gently, the cerebellum is retracted. We reach the cisterna magna there, and it has 2 layers of arachnoid. One is superior and inferior. Both are opened and CSF is let out. You can see now the cerebellum becomes lax and pulsating. Once that is done, now you see the cerebellum is very lax. Gently, the cerebellum is retracted and the cystic component of the tumor is exposed. The most important step here, usually these lesions are intraarachnoid. The arachnoid of the lateral cerebello brainstem space is opened widely. This is very important to have smooth and comfortable, safe excision. Once the arachnoid is open, the tumor cyst wall or the capsule is open and the tumor cyst is let out. Again, that helps in reduction of the pressure or the mass effect on the cerebellum and cerebellum becomes lax. Once that is done, next important step is to start the devascularization and debulking the tumor. You can see now the tumor, the solid component of the tumor, and there is a cystic component which is already drained. Now I want you to see inferior pole of the tumor. We start the dissection. You can see now the jugular bulb transmitting 9th, 10th and 11th cranial nerves. The facial vestibulocochlear nerve complex is shifted or displaced inferiorly and downwards, and there is good plane of cleavage between the tumor and these nerves through the arachnoid. This plane of cleavage is always maintained. The surface of the tumor is coagulated. Now I want you to see on the surface of the tumor, you are seeing the nerve fibers coursing, which are inseparably fused with the tumor. These are the nerve fibers giving origin to the tumor. Inferior part, probably the lower rootlets of the trigeminal nerve, sensory rootlets originating from the medulla oblongata and upper cervical spinal cord, predominantly sensory fibers which are there. Now, these fibers we try to separate and preserve them as much as possible. The capsule is open and internal debulking of the tumor is started as shown here, and the inferior part of the tumor is debulked. Now superior part of the tumor is gently brought into the operating field and debulked and separated from the surrounding cerebellum and neurovascular structures. There is a Dandy's vein, petrosal vein on the surface of the tumor, which needs to be preserved and protected under any circumstances. We are going the deeper part of the solid component of the tumor is being debulked. Now you can see once we do that, the anterior part of the tumor is easily and gently is being separated from the petrous part, posterior part of the petrous bone, and that part of the tumor is held and removed in a piecemeal from the main part of the tumor, which is adherent to the lower nerves or lower rootlets of the trigeminal nerve, predominantly sensory, coming from the medulla oblongata and upper cervical spinal cord. These fibers usually supply the ophthalmic division, probably the superior part of the face, forehead, and the frontal region. This is the tumor, which is lower part, inseparably fused with these nerve fibers. We try to protect these nerve fibers as much as possible. And here, majority of the time, the tumor usually arises from few rootlets, and many of the fibers or the roots of the trigeminal nerve, with fine dissection under high illumination and high magnification, we can preserve many of the roots of the trigeminal nerve, and we can preserve this. This you can see now we have preserved the significant part of the lower part of the rootlet of the trigeminal nerve, and tumor is separated from there. Now the medial most part of the tumor from the anterior part of the pons, medulla, and midbrain are being gently dissected and removed. That is, the middle part of the tumor from the pons and lower midbrain is separated in the arachnoidal plane anterior to the pons and midbrain, brought into the operating field and removed. That's a part of the tumor going into the trigeminal canal, into the petrous temporal bone anteriorly at the region of the apicular region. That is coagulated and detached from there and gently pulled down and removed. At all this time, we need to keep watching for the deeper parts of the trigeminal nerve and keep looking for it, because now we are sure it is originating from the inferior part. The superior and middle part of the trigeminal nerve need to be visualized and preserved under any circumstances, especially the ophthalmic division. Now you can see the part of the tumor is being gently removed below the tentorium at the level of the trigeminal canal, and there is a good amount of arachnoidal plane which is preserved and removed. Once we do that, now the tumor here is extending below the tentorium cerebelli and the superior part of the cerebellum and the ambient cistern as it was seen on the MRI. Now you can see the tumor there adherent to the tentorium cerebelli inferiorly. Arachnoid is opened and the tumor is separated. During this process, the trochlear nerve posteriorly originating from the midbrain comes in the view, and you can see that it is densely adherent to the capsule with sharp dissection. This nerve, trochlear nerve, fourth cranial nerve, is separated and pushed superiorly and posteriorly away from the operating field, and tumor capsule is gently brought down and taken out. This takes some time, needs to be done patiently. Under any circumstances, the trochlear nerve should be preserved and protected. Now, once that is separated, the superior part and the medialmost part below the tentorium cerebelli is dissected completely. That's an arachnoidal plane where the tumor is there. Now, the tumor is totally separated from all around, superiorly, inferiorly, laterally, and medially is separated, and whole tumor capsule can be extracted in multiple pieces as shown here. This is the complete resection of the tumor. That's the medialmost part adherent to the pons, which is coagulated and cut with a sharp dissection and removed. That is the part of the tumor which is medialmost adherent to the pons in the arachnoidal plane. That plane needs to be maintained always. Here we may have some bleeding from the surface of the capsule. All our coagulation should be on the surface of the capsule and not towards the brainstem. And that is the complete excision. That's a tumor arachnoid which is removed. Once that is done, you can see now complete removal of the lesion is there, and the trigeminal nerve, superior and mid part of the trigeminal nerve, is very well preserved and protected and seen coursing it to the trigeminal canal. Now you can see that's a trigeminal now superiorly. It shifted superiorly and anteriorly. And now you can see the basilar artery, anterior lateral part of the pons and midbrain. You can see that, and the perforators from the basilar artery. That's the sixth nerve, abducent nerve, entering into the Dorlow's canal. These are the lower cranial nerves, seventh, eighth complex. You can see that's the seventh, eighth complex going pushed inferiorly and posteriorly, now coursing anteriorly, entering into the internal auditory matrix. That's a trigeminal nerve. You can see the well protected and preserved Dandy's vein. You can see the basilar artery and perforators to the cerebellum and the brainstem. Superior part is removed completely. Trochlear nerve is very well preserved. That's the lateral part below the tentorium and lateral midbrain. That's ambient cistern. Absolute hemostasis is achieved in these places. Now coming down into the lateral cerebello brainstem space. Here cerebellum is lax and pulsating, and the cerebellum is gently retracted. That part is covered with the surgicel to avoid small oozes postoperatively. This is the complete excision of the lesion. Now at this juncture we bring in the endoscope, confirm the completeness of the excision and hemostasis, and if there is any remnant tumor. You can see the jugular bulb, lower cranial nerves going there, internal auditory meatus, 7th, 8th nerves, Dorlow's canal, 6th nerve. Superiorly, you can see the trigeminal nerve entering into trigeminal canal. You can see the superior cerebellar artery and tentorium cerebelli, and below superior part of the cerebellum. These are the microsurgical anatomy shown very well. All the cranial nerves, 4th, 5th, 6th, 7th, 8th, 9th, 10th, and 11th cranial nerves are very well preserved. Vessels are very well preserved. That's a 6th nerve. 7th, 8th complex, internal auditory meatus getting into. That's a jugular bulb or jugular foramen. 7th, 8th, 9th, and 9th, 10th, and 11th cranial nerves entering there. Absolute hemostasis is achieved. You can see the end stage of surgery. We ask the anesthetist to increase the blood pressure by 30 to 40 millimeters of mercury before we close, so that confirm that there is no ooze in the tumor bed. Cerebellum is lax and pulsating. Confirm the absolute hemostasis for 15 to 20 minutes. Dura mater is closed with the pericranial graft. We prefer always pericranium rather than artificial dura. Acceptance is better. Infection chances are less. Bone flap is replaced and fixed. Scalp is closed in 2 layers. Same day evening CT scan shows complete excision, no hemorrhage, edema, swelling, and infarction. Ventricles are normal. This is her post-op clinical status on day 2. Glasgow score 15, no deficits. Lower left side, grade 1, grade 2 facial paresis, and no deficits. He's taking orally. This is our neuroanesthesia team, treating physician and neuro rehab team. Our presence online with more than 640 microsurgical, exoscopic, endoscopic, navigation guided, educative, neurosurgical, operative, procedural videos on YouTube Neurosurgical Educative Video Atlas. Thank you very much for viewing.